Ranjit, Ranjit, kindly contact other doctors also.
Yes, sir. Just this Palniappan doctor is connect. Both
हाँ,
are connecting, sir. They are with their laptops. They are connecting.
हेलो मिठुन।
Indranil. Yes, sir.
हाँ, अच्छा अच्छा क्वेश्चंस तैयार हो गया है
हाँ
आज। अच्छा क्वेश्चंस तैयार हुआ है।
हाँ हाँ सर।
हाँ, अगर टाइम मिलेगा अच्छा डिस्कशन होगा आज।
हाँ श्योर सर।
हम्म। क्या हुआ सुशांत सिंह राजपूत को, क्या हुआ क्या?
आई थिंक ही सुसाइड हो गया।
क्यों किया? ये तो बहुत हीरो था सबका,
हाँ हाँ
धोनी का फेस था।
हाँ। Strange, very strange. He was at the peak of his career.
हम्म।
डॉक्टर इंद्रनील, आप अपना वीडियो और कैमरा ऑन करिए ना।
हाँ
साउंड
बोलिए।
एंड कैमरा। हाँ,
हाँ हाँ हाँ, चेक कर लीजिए।
एक सेकंड एक सेकंड। और
हाँ
रिसीविंग अभी चालू होगा। हम लोग का
हाँ।
पिक्चर नहीं आ रहा होगा आपको अभी।
नहीं 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 नहीं, चालू नहीं आपका कुछ कुछ नहीं आ रहा है, कोई पिक्चर्स नहीं आ रहा
हाँ,
है।
एक एक सेकंड। वो ये नए वाले उसमें है ना, थोड़ा सा टाइम लगता है आज। देयर इज लिटिल आई थिंक दिस थिंग।
क्या हुआ आज?
आपका नहीं नहीं, ये रिसीविंग का देख रहा हूँ मैं सिग्नल।
देखिए ना। हम्म।
सिग्नल बराबर है आपका सर आज।
हम्म।
आना चाहिए, अब आना शुरू हो गया। आपको आ
कितना?
रहा होगा पिक्चर। पिक्चर आ रहा होगा हमारा।
हाँ
अभी
आपका।
बराबर है, 320 180 पे आ रहा है।
हाँ 320 180 वो क्या है?
पिक्सल
ओ अच्छा अच्छा।
रेजोल्यूशन है 321।
हाँ अभी तो आपका
आइडियल
आ रहा है।
640 होता है।
हम्म।
हाँ, थोड़ा आपका सिग्नल बेटर हुआ तो 640 तक जाएगा वो।
मेरा सिग्नल।
640 इज अ गुड। हाँ,
अच्छा
थोड़ा और।
तो ठीक है, देखता हूँ, मेरा दो कनेक्शंस है।
हाँ, आज के आपने क्वेश्चंस भी भेज दिए हैं मिस्टर मिथुन।
संदीप जी।
डॉक्टर कहाँ है यार? 642 हो रहा है, तो 7 o'clock शुरू कैसे करोगे? एक डॉक्टर तो आपका फर्स्ट टाइम ही आ रहा है आज।
Yes, yes. We have informed them. Mr. Ranjit is following up.
अरे मिथुन जी, लेट आएगा आपका प्रोग्राम शुरू नहीं हो पाएगा। मेरा सिर्फ
What
कहना
did
ये है,
I
वो डॉक्टर आएंगे संपत कुमार, उनका टेस्टिंग भी करना जरूरी है ना। ही इज कमिंग फॉर द फर्स्ट टाइम। मैं कल यही बोल रहा था। वो अपन बोल रहे थे प्रोग्राम के पहले आ जाएंगे, 1 घंटा पहले। वो होता नहीं है।
संदीप जी, मैं आपको नंबर्स भेज के रखा हूँ डॉक्टर्स का।
नहीं सी, हम लोग के बोलने से नहीं होगा ना। 20 मिनट्स बचा हुआ है।
हाँ
कंफ्यूजन क्रिएट करने की जगह बेटर डॉक्टर या आप डायरेक्ट बात कर लेंगे तो वो बेटर है। टेक्निकल इशू आएगा तो वी विल रिजॉल्व इट इमीडिएटली। अभी क्या है, हम लोग भी कॉल करेंगे ना तो वो ही विल थिंक कि ये क्या है। कंफ्यूजन ऐड नहीं करूं, मैं ये सोच रहा था। आई एम जस्ट वेटिंग फॉर हिम टू टर्न अप। हाँ, अभी अच्छा आया आपका।
अच्छा है।
ट्रांसलेशन भी अच्छा हो गया। अच्छा हुआ
हम्म।
था।
हम्म।
साउंड साउंड तो बराबर आ रहा है आपका, कोई इशू नहीं है।
हम्म।
आज आपने क्वेश्चन भी भेज के रखे हुए हैं।
सब सब सब।
दैट इज बैकअप
हम्म।
है क्या वो? दैट इज अ बैकअप ना, मतलब आप ही लोगे ना वो क्वेश्चंस तो।
मतलब
एक आपने भेजा है ना PFA क्वेश्चंस
हाँ नहीं
ग्लाइसेमिक
नहीं
टारगेटिंग।
नहीं नहीं वो मैं मेरे लिए है। आई लास्ट देम ना।
ठीक है,
वो ऐसा बैक हाँ
ठीक है,
वो
ठीक है।
रिप्लाई कर दिया ना तो सबके बस चले गए।
ओके, ओके, ठीक है, कोई प्रॉब्लम नहीं है। नहीं, क्या स्लाइड बैकअप आई कीप, तो दैट्स द थिंग।
नहीं ठीक है।
स्लाइड्स का बैकअप रखता हूँ।
ना
हाँ
वो तो
हाँ
बहुत जरूरी है वो।
हाँ, कभी प्रेजेंटेशन ब्रेक होता है तो
हम्म।
कैन कुछ होगा।
Ji, we need to have the doctors now. Sandeep ji,
बोलिए ना।
Sandeep ji, Dr. Palinappan is telling our technical team to call us. He is finding it difficult to log in.
अरे बाबा यार, कल तो लॉग इन किया था उनने, मैं देखता हूँ एक सेकंड।
Ah, but abhi today he is finding difficult. Please call him. Hello? And the guy.
Yes, joined. Yes, joined. Yes, joined.
Okay, he has joined.
ज्वाइंट, ओके, या
And the caller may.
डेस्कटॉप।
Okay. What shall I do? I am not able to
So you are not
see other
visible.
faces. I am visible, but others are not visible.
Yeah, sir, your signals are weak actually. Now you must be seeing us, sir. The internet signal are weak. We are able to see you now, and you must be able to see us also, sir. But video is coming slightly slow. Do you have any Wi-Fi or hotspot? If you have, it will be good, sir.
Oh, Wi-Fi.
Signals are,
Signals are weak.
yeah,
Huh?
signals are,
I am
yeah, sir. In bit,
Hmm.
signals are little weak, sir.
Mhm.
It is coming and going. That's the only thing.
It's a full. Full only.
Uh-huh.
இந்த ஜன்னல் திறந்து விடுறியாப்பா சிக்னல்ஸ் வீக்ன்றாங்க.
Do you have any phone Wi-Fi, sir? Are you on a phone Wi-Fi, sir?
No, directly a separate Wi-Fi I am having.
Okay. Because signal is coming and going. That's the only thing, you know. The sending one and the receiving one. If you have any phone Wi-Fi, you can take that. But phone should not come. Then it is okay.
Oh. It's a signal ಇದೆಯಲ್ಲ signal circle ಇருக்கு ಸರ್.
Any other Wi-Fi? Yeah, sir, you want to share the screen? Just share the screen. We will check the presentation.
No. Video I have to click on.
Sir, you have to click the share screen, the third button. After the mic, there is, yeah, after the mic, there is a share screen. You select that and select the
Yeah.
first option. Click here to start sharing screen. Just do click that. Sir,
Experiencing technical difficulties. Some features are more difficult. You're sharing screen one.
yeah, sir. I was trying your number. After the mic icon, there is a share screen. Just click on the first option in that. Click here to start sharing screen.
Switch screen to share.
No, no, no,
Click
no,
here
no.
to start share.
Just click on that. But
Okay.
sir, your actually signals are coming and going, so we will lose the presentation. Sir, if you permit, should I make your presentation from here? Hello?
Has logged out. Logged out.
वही
Left the
प्रॉब्लम हो रहा है.
again joined. Yes, sir has joined again.
सिग्नल का प्रॉब्लम हो रहा है मिथुन जी. कैन रंजीत tell him?
Sir, sir, this
Ranjit?
Sampath sir also finding difficult to connect, sir. You please
यार,
guide him also.
No, he has he logged in via the app?
Yes, yes, he has done, sir. He told me that I have downloaded everything, but I couldn't able
Ranjit,
to
but the
join.
problem is now we are only left with 10 minutes here. You know,
Yes, yes, yes.
this is not right here.
The number you have dialed is currently busy.
His number is coming
Try
busy.
Yeah,
Dr. Paniliyappan, can I make
Yeah.
your presentation? I have a presentation. Hello.
Okay.
So I will make the presentation, just see if it is correct. You just have to say next because your signals are weak. So sometimes it will come, sometimes it will not come, but voice will definitely come. Hello. Why is he logging out?
Hello.
Yeah, Dr. Panliyappan, don't,
Yeah.
I think every time you are just logging out or maybe signals are going weak. I'm just sharing your presentation now, sir. Just see if you are able to see it and you just have to say next. I will make your presentation. Can you see it now? Can you see it now, sir? Your presentation?
Presentation I am not able to see.
Not able to see right now? Hello?
Hello.
Yeah, can you see it now or you're not able to see now? Hello? Good evening.
Please try later. நீங்கள் டயல் செய்த எண் தற்போது பிஸியாக உள்ளது.
मिथुन जी,
தயவு செய்து பின்னர் முயற்சிக்கவும்.
हेलो.
आपके पास डायल किया गया नंबर अभी व्यस्त है. You have dialed is currently busy. Please try later. நீங்கள் டயல் செய்த எண் தற்போது பிஸியாக உள்ளது. தயவு செய்து பின்னர் முயற்சிக்கவும். आपके द्वारा
हेलो मिस्टर मिथुन.
Yes, yes.
और डॉक्टर का फोन इज कंटिन्यूसली कमिंग बिजी. डॉक्टर संपत कुमार.
Dr. Sampath, Ranjit.
Ranjit is trying. Ranjit is trying.
Okay.
Dr.
Ranjit is
Panaliyappan.
trying. Palaniappan, you can just check.
No, I had a talk with doctor. His signals are weak. So in between क्या हो रहा है? His call is मतलब his video is getting disconnected. Video and the whole connection. So he is coming back via the 4G. He is telling because network issue is coming every time.
You can change the place.
Just no. He is telling I'll use 4G. So which is better? You just talk to him, Vijay, if possible, and tell him to log out from here and then log in again with the 4G. Right? Dilip,
Okay.
the doctor has come again. Doctor, 1 minute. I'll
This
check.
is okay, I think.
Yeah.
Yeah,
This is.
are good. We can
Yeah,
see the
yeah.
quality
Now-
of the yes.
Now it is coming good, sir. Dr. Panliyappan, can you share the screen now, sir? It is next to the mic icon. There is a share screen icon.
1 minute. Share. 1 minute.
Doctor Arvind, you are able to hear us? Pardon, sir? Okay, great, sir. Increase the volume of your laptop. You'll get a better sound. Yeah.
I'm audible now?
Yeah, perfect. Now it is coming perfect, sir. Very good.
Yeah. Now,
Yeah, doc-
I'm audible?
Yeah. You are audible, sir. And it is coming good also, right now.
It's good, sir. Good.
Sir, next to mic icon, there is a share screen icon. Just click on that. Okay, Dr. Sampath.
Share screen, huh?
Is a TV-like
It's a share
option.
screen.
There is a share screen option, like a TV-like option is there. With
What
after the mic,
it is telling,
after
sir?
the mic, there is
Yeah.
a TV-like option, say share screen.
Not getting launched.
Yeah, this one. Video option.
Sir,
Share
what you
screen,
do
yeah.
is you join as a guest.
You have to
Join as a guest. Join as a guest. Sir, just you click on join as a guest.
okay.
Sir, now you share your presentation. So just join as a guest.
So open
And
your
your
presentation. sir.
number has come, sir. The meeting ID will be there, 16. Just enter the meeting ID, no passcode. Just enter your name and join. Okay.
Sir, just share your presentation. We can
Sir,
see your screen.
Sir,
We can see
just Dr. Panliyappan, just minimize it from the top. Yellow button, just minimize the screen and open your presentation. Just go to, yellow button in Mac, you click. Yes, sir. Just click on this, it will minimize. Now open your presentation, sir.
Yeah. Is it visible?
Yes, yes.
The full
That's
screen.
full screen you
Full
do
screen,
it, sir.
sir. Full screen.
Full screen. Yeah.
Yeah.
Okay.
Yes. Very
Now, is it
excellent.
visible now?
Yeah, sir. Achievement of better glycemic target and OP care during COVID period. Yeah, sir.
Sandeep, sir. Sandeep,
Re-
Vijay,
Going
Vijay.
good. Oh, yeah.
Sir, move the slide, sir. One or two slides you move. Yes. And sir, in case if slide gets stuck up, just do the right click and
Okay.
press the next button. It will move.
Okay.
You can do stop sharing, sir.
When shall we start?
Hello, Dr. Sampath. Are you able to log in now?
Exit the screen, sir. Kindly exit the screen.
Yeah.
Go on the desktop.
Pardon, sir? Sir, what you are saying? Sir, just to stop sharing now. Dr. Panliyappan, do the stop sharing. We will do it, sir. Okay.
Okay.
Yeah, sir, no problem.
Yeah, Sandeep ji, I think we should start. Let Dr. Sampath join in a little because
Yeah,
it's
yeah.
already, 7 o'clock.
Just give me a minute. Just give me a minute. We will start.
Anni.
Yeah, just a second. We will start it now. Dr. Indranil, you can put the slide now.
I can share the screen.
Yes,
Yeah,
sir.
please do it, sir.
Okay, I'm doing it now.
Yeah. So we can start the meeting now and Dr. Sampath will join.
Can I start?
Yeah.
Yes, sir. Yeah, please start.
Okay. Good evening, everybody. Welcome to Experts Outlook live webinar series. Welcome to the program. I'm Dr. Indranil Purkar, General Manager of Medical Services, Ipca Laboratories. I welcome you to this program where we have a feast of scientific discussion which is lined up today. We have a very unique combination which is there. We have a diabetologist, we have a cardiologist, and also a nephrologist or a kidney specialist who is there today, who will take us to different aspects of management. So first I would like to welcome and introduce Dr. V. Palaniappan. He is MD FICP. He is a cardiodiabetologist. He is a National API Governing Council member 2019 to 2022. He is currently holding that position and also in the past for 3 years from 2014 to 2017. He is the organizing secretary, Tamil Nadu State Chapter API, currently starting from 2018 to 2021. He is the editor Tapicon Medical Update Book 2018 and 2011. He received the prestigious 2017 Alumni Award from PSG and Sons Charities, Coimbatore. He published various topics in Medicine Update and Progress in Medicine Book in Epicon and Tapicon in various states of API and FAQ books and also TNAPIG. He's a young dynamic speaker in different conferences, API, TAPI, RSSDI, BPCon, HSICon, TRSC, and Dr. Mohan's International Diabetes Update and various branches of National API and IMA. He's introduced 10 new gold medals for MD PG students in Tamil Nadu and Pondicherry API since 2011. I welcome Dr. Palaniappan to today's program. Next, I would like to welcome and introduce Dr. S. Aravinda Kumar. He is an MBBS, MD, General Medicine and DNB in Cardiology. He is the head of Department of Cardiology at Kaveri Heart Hospital, Trichy. He has a special interest in the field of primary angioplasties. He organizes health awareness programs in the field of primary prevention for general public for more than 10 years. He has an active involvement in teaching academics with various scientific bodies which include APA and IMA. He has active participation in conducting in conferences and workshops. I would like to welcome Dr. S. Aravind Kumar. Next, I would like to introduce Dr. K. Sampath Kumar. He is an MD, DNB, DM, and FRCP from Glasgow. He is a senior consultant nephrologist. He is presently Secretary of NATPU, Nephrology Association of Tamil Nadu and Puducherry, Vice President of Indian Society of Nephrology Southern Chapter. He is a member of various societies, some of which include International Society of Nephrology, Indian Society of Nephrology, and Associations of Physicians of India. He has more than 50 articles, reviews, book chapters, original studies, and case reports in various national and international journals. He is a deputy editor of Indian Journal of Peritoneal Dialysis, also an editorial board of International Urology and Nephrology Journal. I would like to welcome Dr. K. Sampath Kumar to today's program. So, let us share with you today's agenda. As I said, we have a unique mix of an endocrinologist, we have a nephrologist and a cardiologist into this program who will take us to different aspects of management of diabetes, ACS, and AKI and dyslipidemia. The first topic one, achievement of better glycemic targets in OP care during COVID-19 period, Dr. V. Palaniappan. Topic number two, secrets in management of ACS in COVID-19 period, Dr. S. Aravinda Kumar. Topic number three, management of AKI and dyslipidemia in ICU, Dr. K. Sampath Kumar. First, I would like to welcome Dr. V. Palaniappan to take us to the first presentation, which is achievement of better glycemic targets in OP care, outpatient care during COVID-19 period. Welcome to you.
Yeah. Good evening to everyone, ladies and gentlemen. Thank you very much, Ipca Pharmaceutical people, and especially my dear friend Mr. Johnny and Ranjit Kumar and all the team members for giving me this wonderful opportunity. Today my topic is in outpatients care during COVID-19 period. What is the association between diabetes and COVID-19? So, lot of morbidity, mortalities are going across the world pandemic virus, COVID-19, so-called SARS-CoV.
Hello, Dr. Palaniappan. Hello, is it Dr. Palaniappan? His signal has gone. So can you improve the signal? Can you ask him to stop the presentation because we are not able to get his presentation and the voice both. I will ask the other doctor to start the presentation. Can you give the phone to him? Hello? Hello? Yes, sir, your signal and voice both have gone. The signal is not coming. So what I will do is I will ask Dr. Arvind to start the presentation. And meanwhile, what you can do, can you join by phone? I'll make your presentation, sir, from here, if you don't mind. You can join by phone. I think signal will better. I'll ask Dr. Arvind to start now. Okay, na? Okay. Dr. Arvind, can you start the presentation, sir, please?
Definitely, I'll do. Is it visible now?
Yes, sir. It is coming perfect.
Can I go ahead and present?
Yeah, please. Yeah, please go ahead, sir.
Okay. Fine. So, good evening. This is Dr. Arvind Kumar from Trichy Kaveri Hospital. Next few minutes, I'll be talking about management of AC during the COVID-19 period. Unfortunately, Dr. Arvind signals are very weak and I'm just taking as a backup. Just for the next few minutes, I'll be talking about how to manage coronary artery disease. So the spectrum of coronary artery syndromes extends from the risk factors to the end-stage heart failure, varying from acute coronary syndrome to chronic coronary syndrome. So what I am concerned about in the current, the next 20 minutes is management of ACS in this scenario. So first I'll take STEMI as management. How do you manage? So in any STEMI, as you know, what we require is the total ischemic time which we are looking into. So predominantly we try to get the total ischemic time to the shortest possible so that you have better morbidity and mortality outcome overall in the management of ST. So how do you want to do it? So precisely it is easier. The patient, once the symptom is there, is aware and he comes into the hospital. We have to ensure that they come to the hospital at a much earlier time once the symptom is set in. Then once within the hospital, you have to have a meticulous way of managing in such a way that ECG is taken within 10 minutes, you will take a decision whether to thrombolize or to do a primary PCI. And most of the centers, it's only fibrinolysis still in India. There are other few centers like us where primary PCA is possible, then we have to go ahead and do the best possible treatment for the patient, that is primary PCA, which is doing an angiogram, opening the coronary artery after visualizing and getting things done properly. So that gives a better outcome for only the myocardium is salvaged in a larger extent. Whereas fibrinolysis, you are not really well aware that whether the coronary artery is open or not. So this you have to do it within 120 minutes. That is the maximum time which you can do. Otherwise, if it is getting delayed in a non-PCA center or transferred from a non-PCA center to a PCA center, then still fibrinolysis is the treatment of choice. So what has changed recently? Recently it has been there. Initially we thought the first 3 hours, the golden hour for fibrinolysis. First 1 hour is the golden hour actually. First 3 hours, up to the 3 hours, there is no hassle in my lysis. Most of the time, a good lysis agent like a tenecteplase or retaplase can give as good a result, myocardial salvage, as a primary PCA. But if it is not possible to have it, then primary PCA is the best choice. Beyond 3 hours, what to do? That's the question. Most of the Indian patients come beyond 3 hours. For the next 12 hours, up to 12 hours, fibrinolysis is also indicated in the patient has ongoing chest pain, hemodynamic instability, or an arrhythmia is there. Then fibrinolysis is also the indication is there, provided the patient is not in a PCA center. If the PCA capable center is there, then PCA is the order. So beyond 12 hours, what to do? This is the current change which has there. The evolved STEMI. Initially, the evolved STEMI, there was no indication for lysis or primary PCA. So after 12 hours, the lysis part is completely out. No more lysis after 12 hours. That is one carry-home message. After 12 hours, what you have to do is you can take up the patient up to 48 hours for primary PCA if the patient has symptoms. Chest pain, ongoing persistent chest pain, hemodynamic instability, or an arrhythmia is there, then you have to do a primary PCA. Even in asymptomatic patients, up to 48 hours. Now the guidelines have been extended for doing even in the asymptomatic stable patient, primary PCA can be done. It is not class 1, it is class 2A. The reason when it crosses beyond 48 hours, that means that likely that myocardium is completely necrosed. Beyond that, there is no point in trying to do a primary PCA. After that, it's all about managing the patient, then taking the patient for an angiogram and address the other vessels predominantly after doing a viability study. So to make it very simple, STEMI management, as you know, this is the ideal way to manage. If there is a primary PCA capable center, primary PCA within 120 minutes. If it's not there, then if it is not there, then you have to do fibrinolysis in most centers. So this is what the order. Most of the time it works well, but how it's going to work in COVID situation, that's what we need to do. Moving next rapid to the non-ST elevation MI. So with non-ST elevation MI, you know, there is no ST elevation, simple basic. It could be a minor ST2 changes, or it could be a elevation of troponin. So you risk stratify the patient. That is most important. The elderly patient, multiple risk factors, especially diabetes, prior visualization of a coronary stenosis in angiogram, ST deviation, at least 2 anginal events in the rest time in the last 24 hours, use of aspirin, and elevated cardiac biomarkers. If it is there, according to that risk stratification, if you are able to risk stratify, then it is easier to manage the patient with an unstable angina or non-estimation. Here you risk stratify with the risk score. As you are seeing in the slide, more the risk score is, more likely the patient is going to die within 2 weeks. So with the 6 or 7, patient is going to die. 40% of chance the patient is going to have a morbidity or mortality during the next 2 weeks. So it means medical management is not going to work in a high risk situation. There you have to do intervention. So this is what you have to do. So once you diagnose an unstable angina or a non-estimation, right? You have to, this is basically, you have to load the patient with a dual antiplatelet. You have to give an statin. Accordingly, you have to nitrate, beta blocker, AC emitter, all are mandatory. So you have to decide whether the patient requires a initial conservative therapy or a invasive therapy. The higher risk group, higher the risk stratification, your risk score wise, if it is more than 2 to 7, then you are likely that the angiogram and further stratification is useful. If it is less than 1 or 2, then you can manage conservatively, do a treadmill after 2 weeks. This is what the criteria and guidelines is. And accordingly you can manage. Once you do an angiogram, you get planned either your PCA or CABG according to the angiogram, angiographic visualization of the disease. One thing you should not do in non-estivation MI. If there is no estivation MI, you should never thrombolyze. There is another one carries a message. You should never thrombolyze. Especially we will be tempted to do a thrombolysis in a ST elevation in AVR and V1, thinking that two leads continuous leads are having ST elevation and rest all ST depression. This is a typical left main coronary artery disease feature where there is a critical lesion in the left main coronary artery. This critical lesion in the left main coronary artery disease means simple. It is not a completely occluded. If it is completely occluded, patient will not reach your hospital 99% of the time. So it means that it is subtotal occlusion is there. Since it is not completely occluded, it is not distillation, do not lyse. By lysing the white thrombus, it is going to aggravate the whole scenario, and as you see in this slide, it is going to increase the mortality. So do not lyse in a stage in a LMCA suspected patient, just because there is escalation in AVR and V1. So it has to be there, continuous leads which will be there in either the anterior or inferior leads should be there. So the initial treatment in a non-escalation and unstable angina will be invasive treatment. If the risk factor is more than 5, definitely it has to be there. 2 to 5 according to the patient. Less than 2, it's medical management. As simple as that. So to put it simply, higher the age, prayer obstruction, recurrent rest pain within the 24 hours, STT changes, troponin elevation, then you require a intervention. So this
Sir, your presentation, can you share it because it is not shown now? Just now, presentation, can you reshare it?
Now it is free?
Yes.
Now to make it very simple, the non-escalation unstable angina, risk stratify the patient. If it is low risk, patient initially medically managed. Simple initial therapy, aspirin, clopidogrel or ticagrelor or prasugrel, then beta blocker, nitrate, statin. So apart from that, you have the low molecular weight heparin or unfractured, and you have to do a pre-test, or ideally I do it after 2 weeks as treadmill testing and risk stratify the patient. Intermediate risk between risk score between 3 and 4, you have to ensure that if there is a multiple risk factors, you have to go send the patient for an angiography. And high risk patient, there is no question of medical management. The mortality and morbidity is very high. You have to start send the patient for an initial angiogram. So once in the angiogram, there is going to be a triple vessel disease or a left main disease or a left double vessel disease, including a proximal area. Patient goes for a CABG. If the rest of the disease goes for a PCA, if it is not affordable or it is a minor disease, then the patient goes for a medical man. As simple as that. So this is the ideal scenario what we have been practicing for a long, long time. For the last 2 or 3 decades, we have been doing it without any hassle. Now,
Sir, can you reshare the presentation, please?
oh my God. So this is all your. Is it visible now?
Yes, sir. Yes, sir.
Take all your management of ST elevation MI and non-ST elevation MI are all there, but what all this evidence has shown, or as we have been practicing, is not going to be applicable at this point of time in COVID crisis, where survival of patient, survival of the doctor, survival of the hospital, everything comes into play. Now, COVID. Now I'll come to the topic proper. So COVID, this, as you know, it involves all organs practically. Now the latest paper shows that all neurological nerves are also involved in the virus has been infecting and infestating the neural system. And you know, every organ is involved, and the heart and the lungs are the predominant organ which is likely to be involved. And the available natural history in our India is most of 80 to 88% what our data says is asymptomatic to mild, where they do not have any symptoms, even the lung involvement or the heart involvement is there. They come as a URI and go out. In 10 to 15% of the mild to moderate and 5 to 8% of the moderate to severe COVID has some problem. So initially, the most of the time we are concentrating on the COVID pneumonia, which is very, very dangerous, and more importantly, and the second one is the cytokine storm, which is there, which is also very, very dangerous. That comes after the 7 to 14 days. At that point of time, you are going to land up in lot of trouble. So where does the heart come at this point of time? So among the severe patients, the heart disease, heart involvement is there in 40 to 70% of the patients. So it means that out of 100 patients with COVID, you are likely to have 5 to 8% of moderate to severe disease. So among them, 40 to 70% can have cardiac involvement. It means that out of 100 patients, 3 to 4 patients can have cardiac abnormality. What are the abnormalities it could be? So it could be a direct cardiac injury. That means that the virus infects the cardiac myocyte directly, or a pro-inflammatory cytokine surge, which I was talking earlier. So it could be due to it especially occurs after the 7th day and between the 7th and 14th day. Exactly around 9th to 10th day is the dangerous time of the 5 cytokine storm, which we have to understand. And severe hypoxia due to the severe COVID pneumonia. This can induce a oxidative stress and myocardial injury, upon which the patient can have further worsening of the cardiac function. So a patient can also have a cardiac ECG mimicker myocarditis also. So now we will just see the evolution in the non-perfusive myocarditis. See here, in a routine acute MI, patient has an ST elevation. Then you have a QR pattern where ST elevation is also there, Q is formed. At some point of time, Q is only there and QS pattern comes. So this evolution occurs. This is what normally you see in normal patients. What happens in COVID? ST elevation is there many a times. It is not respecting the arterial pressure. It is not pertaining to LAD, or it is not pertaining to RCA, it is not pertaining to HCA. There will be multiple ST elevation, multiple years. And second thing you have to understand is no reciprocal changes. That is another carry-on message. If there is going to be an inferior wall MI, there is no significant changes in 1 and AVL, or if there is going to be V1, V2, there is going to be an anterior wall MI picture, there may not be ST depression in 2, 3 AVL. So no reciprocal changes is there. And no evolution impact in serial ECG. That is very, very important. If you have to take a serial ECG, after 1 hour, if the evolution is not happening, then you have to start suspecting. And common infralateral lead is the ST elevation which happens in COVID. So this is one thing you have to understand. Going to the echo, people who have an access to echo, it is even though there will be ST elevation somewhere, most of the time you find global hypokinemia. There is no regional variation. There was no regional wall motion abnormality. It is a global hypokinemia predominantly and a severe LV dysfunction. And the rapidly deteriorating LV function. That is what the previous day it will be 40% EF, the next day it will be 30%. It is not going to happen in an acute coronary syndrome. So it rapidly, the myocarditis rapidly kills the myocyte, and you are going to have a deteriorating LV function. And here again, it is not going to respect the arterial perimetry. So now you know that it can mimic an acute coronary syndrome. It can present as myocarditis. It can sometimes present with an arrhythmia. So it can present with pulmonary edema, which you cannot differentiate between a COVID pneumonia. So multiple ways cardiac involvement can be there. How you are going to manage? So now the Indian Heart Journal has clearly shown that managing ACs during COVID-19, do not follow the tradition. Whatever I have told you earlier in the first few slides, both in ST elevation MI and non-ST elevation MI, there are fixed criteria and guidelines which are there, but right now it is not, we cannot apply in all patients because of the safety concern for the patient and for the doctor doing it. So how I am going to do it? So first, how we are going to admit the patient. If the patient doesn't have history of fever in the last 1 week, cough or breathlessness, history of contact, and from containment area, which we can easily identify. If this is there, then you have to suspect it is a COVID. That is the first index suspicion. So you have to have a COVID ward where the patient can be moved to a COVID ICU, and you can have a thrombolysis there. That is not a harm there. So the only thing is this patient should not be a hotspot and transmitting all COVID to the staff and the other patients in the ICU. So if there is no history of it, admit in ICU. If there is ST elevation MI, what I am going to do? So what I am doing is, so if there is ruling out COVID is more important, because once the patient is in the ICU where there is a AC going on, if there is going to be a virus, then it can circulate in the air ducts and keep circulating, and where you know that the paper respiratory article has come that inhaling virus is the most severe form. Viral load is going to be very, very high beyond the contact also. So inhalation virus is most dangerous because it goes well deep into the respiratory tract and cause more problem. So admitting time we do a RT-PCR, HRCT test. So we rule out both days, we rule out asymptomatic carriers. Then thrombolyze the patient. We go back 2 or 3 decades backwards, thrombolyze the patient on admission, because this investigation takes at least 6 or 7 hours to come. You don't want to wait for the patient treatment to happen. And routine management for the next 24 hours. We medically manage the patient. If both the negative RT-PCR and HRCT is negative, I take the patient for an angio and revascularize the patient. So the other one is non-installation. How do I going to do? Here again, it is very simple. At admission, you do a RT-PCR, manage with heparin, glycoprotein 2B3 inhibitor, HRCT test. So then if all these things are negative, then restratify the patient. As I told you earlier, the TIMI risk score is less than 2, I need not do an angio. So just medically manage the patient, discharge and come back after 2 weeks for a treatment. Risk factor between 3 to 5. If there is multiple risk factors there, go ahead and do an angio, and according to the vessel morphology, you have to decide on the treatment plan. If it is 6 or 7 with TIMI risk score, then you have to mandate do an angio. Accordingly, you have to plan. So in unstable angina where there is minor disease, likely to be a smaller disease, conservative management, TMT after 2 weeks and discharge. So now in COVID situation patient, that point of time of admission, treat all patients as COVID positive, unless proved. So this is what that one carries on message. Treat all patients as COVID positive, then only you are safe. Otherwise you are likely to have trouble. If destined to you want to have COVID, have it from community, not from hospital, where the patient is likely to have very, very high viral load. And the chances the patient is going to get, you are going to infect is also high. And you know, once you are in the patient in ICU and the healthcare workers getting infected there, the morbidity and mortality is multiple times higher. It is 10 to 12%. Not as your 1%, 3% mortality. It is 10 to 12%. You have to understand that, and you have to plan your management accordingly. Surviving the pandemic unscathed is your goal. So no heroics now. So you have to manage conservatively. You have to be appropriate in your treatment, but you should not never deny the treatment. You have to have appropriate treatment, and you have to go ahead with proper PPE and go ahead and do it. So you have to have another very good carry-over message is your family needs you. Not that patient also needs you, but most importantly, your family, you are the only person for the family needs you. Stay safe. Thank you very much for your patient care.
Thank you, Dr. Arvind, for your presentation. Very nice presentation from your side. Now, can Dr. Palaniappan join for the completing the presentation? Okay, we can move to Dr. Sampath Kumar. Dr. Kumar.
Can I? Dr. Palaniappan is joining.
He's joining?
Okay. Yeah.
Okay.
தானப்பா வந்துச்சு.
I think let Dr. Sampath Kumar present.
Yes, that's better.
Can I go ahead?
Yes, sir.
Can I start sharing the screen now?
Yes, sir.
Are you able to see the slide?
We can see you. The slide we cannot see.
Okay. Sir, click the share screen and the first option. Click here to start sharing screen. I'm just clicking the share screen. And click here to start sharing screen. The first option. Is it okay now? No, sir, it is not coming. But it is showing that you are sharing the slide. 1 minute, sir. It is not coming. Have you clicked on? Yeah, now it is coming. 1 minute. Okay. You are receiving the presentation.
Yeah.
Now is it okay? Yes.
Now we can see. Yes.
Okay. Shall
you
I
can go ahead.
start now?
Yes, sir. You can start. We can see it properly.
Yeah. So thank you for the excellent opportunity, and I also enjoyed the presentation on the cardiac aspects of COVID. And so I'll just take you on to the acute kidney injury and dyselectrolytemia. I am happy to tell you that the misfortune of treating a COVID positive patient. So I will only take you through how I manage a patient with acute kidney injury and sepsis. So this is a 64-year-old female who was admitted with the... 1 minute, I'm not able to see my slides. So this is a 64-year-old female. Hello?
Yeah, we can see it. We can see your presentation.
Can you hear me also?
Yes, you are very clear. We can see you as well.
Okay. Yeah. So this is a 64-year-old female who was admitted with high fever, dysuria and oliguria last week. She was a diabetic on very poor control of diabetes as usual during these COVID times. She was on insulin and the SGLT2 inhibitor. She had high fever, blood pressure was on the borderline. She had a bilateral flank tenderness. So this is a typical case scenario that you are likely to face in patients with uncontrolled diabetes, because urinary tract infections have become extremely common. When I started my practice 30 years ago, I never used to have cases of acute renal failure with acute pyelonephritis in diabetes. But now it has become extremely common that in a week, at least 2 to 3 patients I admit and then treat in the ICU, patients with urosepsis and acute kidney injury. So this patient's urinary analysis showed a lot of pustules in the urine. Total count was high, sugars were high, and ketones was positive. Urea was 120, creatinine was 4. Electrolytes showed profile of low sodium, high potassium, low bicarbonate and chloride of 95 with an albumin of 3.6. So the arterial blood gas, so whenever you have a patient who is sick with acute kidney injury and with hypotension, it has almost become mandatory now to have an arterial blood gas analysis to inform you about the other areas of pathology.
As usual during these COVID times, she was on insulin and SGLT2 inhibitor. She had high fever, blood pressure was on the
I am hearing echo of my earlier slides. I don't know what is happening.
Sandeep, there is an echo.
I never used to have cases of acute renal failure, acute pyelonephritis and diabetes, but now it has become extremely common.
Hello.
Yes, sir, you can continue.
Okay. The pH is 7.2, telling you that this patient has got severe acidemia. The PCO2 is 20, saying that the carbon dioxide washout is very significant. The bicarbonates are down with 8. The PO2 is 90 and the lactate levels are 5. So again, telling you that this patient is in deep dyselectrolytemic crisis. So the simple approach to this arterial blood gas is that this patient's pH of the blood is less than 7.35, 7.2. A low bicarb and a low PCO2 tells you that the patient has got metabolic acidosis with a high lactate. And immediately when you have a patient with metabolic acidosis, you have to check whether this is the high anion gap metabolic acidosis or a normal anion gap metabolic acidosis. When you check the anion gap, you see that the sodium minus chloride and bicarbonate gives you a value of 21, which makes you suspect that this patient has got a high anion gap metabolic acidosis. So this immediately we went ahead with a CT abdomen because the ultrasound is likely to miss an emphysematous pyelonephritis. So in a patient who is sick with diabetic ketosis and bilateral flank tenderness and sepsis, emphysematous pyelonephritis is diagnosis which has to be excluded quickly. So we went ahead with a CT abdomen which showed emphysematous pyelonephritis of the left kidney and an enlarged right kidney. And perionephric fascia was thickened bilaterally. There was also a hydronephrosis with a papillary necrosis on the right kidney. So this is again, I'm sure all of you are encountering typical case scenarios like this with urosepsis and acute kidney injury. So again, I'm hearing echo. I don't know. There is a real technical glitch. I think it has to be set right. So this patient has acute kidney injury, sepsis, and metabolic acidosis. So how do you define acute kidney injury? It is defined as an abrupt decline in GFR leading to a retention of nitrogenous waste products. It is a preventable catastrophe and is potentially reversible. So how do you know in this patient that the creatinine which has gone up 4 to 4 is an acute process? So it is not easy in India where you don't have the earlier laboratory values. Fortunately, this patient's urea and creatinine were done last month and it was normal. So telling you that this is a sudden acute deterioration of renal function. So you have basically 3 stages. The stage 1 is 1.5 to 1.9 times the baseline, or if the creatinine value rises by a factor of 0.3 milligram. That is the stage 1 AKI. In the stage 2, the creatinine jumps up by a factor of 2 to 2.9 times from the baseline. And the urine output drops by a factor of less than 0.5 ml per kilogram per hour for more than 12 hours. In the stage 3, you have the 3 times baseline elevation of the creatinine, or any creatinine increase to more than 4 milligrams. So, or if there is an anuria for more than 12 hours, or if the urine output is dwindling by a factor of less than 0.3 ml per kilogram per hour for more than 24 hours. So this patient is oligoanuric. This patient's creatinine is more than 4, informing you that this patient has reached already a stage 3. So this is the type of cases with acute kidney injury in our ICU, in our unit. You can see that septic shock is standing head and shoulders above the other causes of acute kidney injury in the ICU, contributing to more than 50%. So almost 60% of cases of acute kidney injury admitted into ICU in our unit are due to septicemia. And whenever you have a situation like this, you need to reach for the very safe fluid. So what is the type of fluid that you have to give is a very important question. And most often we are concentrating on the sodium, the level of sodium in the fluid that we are giving, and also the glucose. But a time has come that we have to concentrate on the twin brother, or the other twin, which is clubbed along with sodium, that is a chloride ion. So we need to look at the chloride ion, because the chloride ion seems to be the troublemaker in the acute kidney injury. It's an ion which has not been given its due, and recent animal and recent clinical trials, observations from field trials in Africa in acute kidney injury in children, have shown that chloride level of the intravenous fluid may influence how the patient is going to fare in acute kidney injury. The avoidance of excessive chloride administration is a reasonable treatment option for all patients at risk of AKI. So, more than the sodium, it is the chloride which you will have to concentrate. And if you see the chloride content of the commonly available fluids, intravenous fluids, you will see that the chloride content of the normal saline is 154 milliequivalents per liter, very high. This is far more than the plasma chloride level, which is only close to 100. So in the Ringer's lactate, it is coming close to the physiological chloride levels of 109. So if at all you have to choose a fluid, it is ideal that you choose Ringer's lactate in your ICU. The common question which arises in the physician's mind is that Ringer lactate contains potassium. So it is important to realize that the potassium content of the Ringer's lactate is extremely small. It is only 4 milliequivalents per liter. And if you are going to give 500 ml of Ringer's lactate, it contains only 2 milliequivalents of potassium, unlikely to create any imbalance, unlikely to create hyperkalemia. So you can boldly go ahead and choose Ringer's lactate in your patients unless he is severely hyperkalemic to a level of more than 5.5 or 6. In all other situations, it is ideal that in the ICU you choose less chloride containing fluid. We have now balanced plasmolite A solutions which contains even lesser chloride of 98. So the next question is to why chloride should be carefully handled and carefully infused in our patients. The reason why chloride levels can create mischief in the renal microvasculature is that there is a physiological feedback inhibition of the glomerular blood flow. Whenever there is an excess chloride which comes through the distal convoluted tubules, the increased tubular chloride is sensed by the juxtaglomerular apparatus, and this produces an increase in the renal vasoconstriction. So hyperchloremia in the afferent arteriole, and also it produces vasoconstriction, and it increases the afferent arteriolar resistance and produces a decreased renal blood flow and perfusion. So you don't want renal blood flow to come down, because this is going to spell trouble by producing renal ischemia and further worsen the acute kidney injury. So the lesser the chloride content of the fluid that you are choosing, the better for the patient. So why metabolic acidosis is bad? We heard a beautiful cardiac presentation by a cardiologist telling us about how acute myocardial infarction can happen in the ICU. Metabolic acidosis is a very important part and parcel of ICU admission in patients, and metabolic acidosis can produce, in addition to coronary artery disease, myocardial depression, reduced contractility, and there is a pump which is there in the myocardium called the sodium hydrogen ion pump. This pump is not effectively pumping out the hydrogen ions from the intracellular compartment, and this can produce excessive myocardial intracellular acidosis and predisposes towards reduced contractility. So situation of acidotic cardiomyopathy develops, and there is also a central venous pooling of blood, telling you that these patients can, lot of blood can come into the central veins and create a problem of pulmonary edema. It also, the metabolic acidosis also decreases the hepatic lactate uptake. So you require a good, quick lactate uptake by the hepatic cells, so that lactate can be metabolized into bicarbonate. This doesn't happen in metabolic acidosis, and so all these conspire together to produce increasing mortality. So you need to address metabolic acidosis in your ICU patients. And how do you manage metabolic acidosis? So the first thing will be to manage the underlying disorder. If the patient has got sepsis, you need to give high antibiotics. For example, in these patients, ideally these patients have to be started on a high dose of either meropenem or imipenem to control the blood sugars, very aggressive control of blood sugars. As Dr. Palaniappan will take us through the issues of blood sugar control in the ICU. Then surgical intervention is very important, and you may have to, once the patient is stabilized with metabolic stability is attained, these patients have to go in for a surgical intervention with ureteric stent. Bicarbonate therapy, a lot of uncertainty hovers around the use of bicarbonate therapy, because there are experimental studies which are available saying that you shouldn't use bicarbonate therapy in metabolic acidosis in all cases, because once you use bicarbonate, this bicarbonate combines with the hydrogen ion and the carbon dioxide is produced. This carbon dioxide can easily diffuse into the cell and produce intracellular acidosis. So there is always a doubt about the bicarbonate therapy in the ICU, but now the doubt is slowly cleared with the help of nicely done studies in the ICU, that you need to use bicarbonate therapy when the pH is 7.2. So our patient's pH is close to 7.2. So there is an element of requirement for bicarbonate therapy in these patients. And also our patient has got lactic acidosis. Lactate level of 5. So bicarbonate therapy, can you just give the 8.4% bicarbonate that we have in our ICU in the ampules? Can we just infuse them? We have to realize that these bicarbonate solutions are very hyperosmolar solutions. The normal osmolality of the plasma is only 280 to 290 milliosmoles. So you realize that the 8.4%, if you are going to give it as an infusion without diluting, then you are going to give a very hyperosmolar solution, which is not physiologically good. It is equivalent to a 6% saline. The sodium content is also so high that you can't use it undiluted. So if you dilute it by a factor of 50%, say you take 1 ml and make it into 2 ml of the soda bicarb, you are making it into a 4.2% solution. This is a moderately hyperosmolar solution and it is equivalent to 3% saline. The ideal way will be to dilute it to 4 times so that it is a mildly hyperosmolar solution where supposing you want to give 500 ml solution, so you take 100 ml of soda bicarb, 8.4%, and dilute it with half normal saline or 5% dextrose of 400 ml. So that will give you 25% dilution. This is ideal that you don't give a very severely hyperosmolar solution. And what is the best evidence that has come out? Recently, a nice randomized control trial was done in the French hospitals in the ICU, where they had 2 groups of patients. One group was given the 4.2% infusion of bicarbonate. The other group was not given that. They realized that the first month survival in the ICU was 63% in early stages of acute kidney injury in the bicarbonate treated arm, whereas it was only 46% in the control arm. So this is a very important message that whenever you are in the ABG, if you get lactic acidosis and also in the when the pH is low, you need to start infusion of bicarbonate, and this is going to provide a survival advantage in your patients. Start infusion early and keep the pH above 7.3. So this is a very good definitive evidence which has come from a control trial, randomized control trial. So what form of dialysis is ideal for this patient? So we have a variety of forms of dialysis, either intermittent hemodialysis or prolonged intermittent renal replacement therapy, in which the typical intermittent hemodialysis setting is used, but the blood flow is kept low, the dialysate flow is also kept low, and the patient is dialyzed for a period ranging from 6 to 8 hours. So this is very ideal for patients who are admitted in ICU, that you provide them with a gentle long dialysis. The other form of dialysis, which is a bit costly, is the continuous forms of dialysis called continuous renal replacement therapy. We also have peritoneal dialysis, which cannot be applied in this patient with an intra-abdominal source of sepsis. So we will not consider peritoneal dialysis in this patient. We will only consider either prolonged intermittent renal replacement therapy or CRRT. A form of CRRT which we have been doing for the past 10 years in the ICU for a hospital is the continuous veno-venous hemodiafiltration, where a form of filtration in addition to diffusion and convection are being used. The dialysate fluid dose and the replacement and the ultrafiltration dose is close to 25 ml per kilogram per hour, which tells you that in a 60 kilogram lady, you need to infuse and also provide effluent of close to 1200 to 1400 ml of dialysate fluid. So this is a very, it is just like putting the plasma and the RBCs of the patient into a washing machine and then wash the plasma and the RBCs thoroughly and then give it back to them. So this is a form of washing machine that we are using in our patients, provides excellent metabolic control. So this is how the blood flow is kept at, I am just taking a photograph of the screen of the CRRT machine. The blood flow is 120 ml per minute. There is anticoagulation with the help of heparin. There is 700 ml of fluid which is going by a pre-pump, and the dialysate is going at a rate of 1000 ml per hour, and the replacement fluid is going at a rate of 300 ml per hour in the post-filter. The patient's fluid removal is 30 ml per hour. So, in effect, 2 liters of fluid, 2 liters of dialysis fluid is circulated, and then it washes in lay terms, it washes the blood and provides convection-based and diffusion-based therapy, which is very ideal in patients who are hypotensive, and these patients can be taken up for CRRT for even a period of 24 to 48 hours. So they can beautifully come out of these problems. So this is the indications, the urea clearance. When you have a patient who is unstable, you will have to, when the patient has got a fluid removal has to be done, large amount of urea clearance needs to be done, and if the patient has got a metabolic acidosis and also brain edema, this is the form of dialysis that you will opt for. In our hospital, in the 1 year period, we had more than 124 patients, and we were able to get a survival benefit of 66% in ICU with multi-organ failure. So again, telling you that CRRT has to be used in selected patients with in the ICU. So I am waiting for the COVID epidemic and the pandemic to peak. I am sure I am going to get cases of multi-organ failure in the COVID positive patient with the acute kidney injury, and these patients will have to be taken up with the CRRT. We also have a form of dialysis called citrate anticoagulation, where if the patient, there are contraindications for heparin, citrate can be used as an anticoagulant. So these patients who are taken up for dialysis, which patients survive and who died. So when the mean arterial pressure is 72 millimeters, then these patients had a good recovery. And when the Apache score, which tells you about how sick they are, if the Apache score is more than 29, they don't do well. Then the serum bicarbonate level is 13 or less than 14, then they don't do well. So in this patient, the serum sodium was 128. Should a serum sodium of 128 be treated? Since the serum sodium above 120 is not associated with significant brain edema, it should not be treated with 3% saline in view of the AKI and severe metabolic acidosis. So you shouldn't be over aggressive in treating mild forms of hyponatremias. And because the problem of hyponatremia is the correction factors have to be very careful, and if you rapidly correct, then osmotic demyelination can happen. So you have to be careful, and you don't go for a 3% saline in these patients unless the sodium levels are less than 120, 115 or 110. You will have to consider using 3% saline. What about potassium of 4.9 in this patient? If you see this diagram, there is a transcellular potassium shift. This can happen when the patient has metabolic acidosis, or when the patient has hyperglycemia with insulin lack. Insulin is an important hormone which pushes the potassium inside the cell. So in the presence of insulin lack in diabetic, hyperglycemia produces increased serum potassium levels from the intracellular compartment. So it is enough if you just manage the metabolic parameters, acidosis correction, sugar correction with insulin, then you don't require a specific anti-hyperkalemic therapy in the form of calcium gluconate and others. So this is the last slide. The key learning points in patients with acute kidney injury in ICU are that multiple acid base and electrolyte disturbances can happen. You need to be careful about choosing the right type of fluid, and you just see the amount of chloride in the fluid that you are giving. Hyperchloremia is a newly recognized risk factor, so go for a low chloride containing fluid in your ICU. Early treatment of metabolic acidosis by bicarbonate infusion is beneficial by reducing the mortality in ICU, and you need to have a stepwise approach to sodium and potassium disorders, and CRRT provides an ideal mode of dialysis for ICU patients with sepsis and acute kidney injury. I'll stop with this and then I'll wait for the others to complete their presentation. Thank you.
Mike.
Hello? Hello? Am I audible?
Yes, sir. You are audible,
Yes,
sir.
Shall I proceed with the slides? Hello?
Yes, you can proceed with the slides, sir. You can proceed, sir. You have put yourself on mute. You are on mute. You have to unmute your button.
Now audible, no?
Yes, yes, yes.
Okay, right. Thank you very much, Johnny and Ranjit Kumar, for giving me this opportunity. Today my topic is achievement of a better glycemic target in OP cap patients during COVID period. What is the best thing actually? Management of diabetes and COVID-19. What is the correlation? In COVID-19 patients, the etiologies SARS-CoV-2 virus, it's transmitted from the bat and human to human transmission is there. There are various antigens, next slide, various antigens are there in that specifically, next slide, RNA and hemoglobin esterase and membrane protein and envelope protein and spike proteins are there. These are all the responsible for inducing the cytokine storm. Once it's entered to the cell wall through ACE2 receptor, it binds with that, and with fusion, it enters into the cell wall, and by uncoating, we are getting genomic RNA, which is positive in PCR technique. After that, through messenger RNA, various types of antigens will be synthesized inside the cell wall, and it will joins with the rough endoplasmic reticulum. After that, it enters the Golgi apparatus. So all the virus antigen will be formed, and it form a virus with vesicles. After exocytosis, it's come out from the cell wall. So various due to the coronavirus COVID-19, we have experienced the pandemic virus across the world. This is the history. Next slide. Next slide. Next one. Next one. Next one. Next one. Next. Yeah. So this is the spread, and the coronavirus main symptoms are fever, high grade fever and difficulty in breathing. These two are very, very important, and diarrhea, vomiting, breathlessness and cough with expectation, everything you can get it. And prevention, how to have a good hygienic environment, everything you know better. And I am going to discuss the association of COVID-19 with the diabetes. Next slide. Next slide. Next slide. Next slide. Yeah. Association of diabetes with acute viral pandemic in the past. If the HbA1c is more than 9%, increase there is 60% increased risk of hospitalization and pneumonia-related severity during bacterial infection. During 2002, that is SARS-CoV-1, it is a diabetes the independent risk factor for the complication and death. In the presence of diabetes, actually in there is swine flu outbreak, influenza A H1N1 in 2009, actually presence of diabetes 3 times increased risk of hospitalization and 4 times increase in the instance of ICU admission. In 2012, the outbreak of that is MERS COVID, diabetes was prevalent in nearly 50% of the population. Odds ratio for severe critical MERS COVID ranges from 7.2 to 15.7 in cohort diabetic cohort patient. Next slide. So association of diabetes in COVID-19 patients ranging from 10% to 30%, and mortality and morbidity also very high in diabetic individuals. Next slide. So case fatality rate is very high when the patient is associated with cardiovascular disease and diabetes and hypertension. If the patient COVID-19 patients are associated with the cardiovascular disease, the case fatality rate is 10.5, diabetes 7.3, hypertension 6%. Next slide. So what is the main pathophysiology? Next slide. Pathophysiology became COVID-19 plus diabetes patient. So main pathophysiology is increased ACE, angiotensin converting enzyme 2 expression is very high, and increased furin. It is involved in entry of coronavirus, and impaired T cell function. CD4 count is reduced, and lymphocytopenia will be there, and increased interleukin 6, which is a very important marker to find out this is the important marker in cytokine storm. So we are going to give the tocilizumab to reduce the interleukin 6, and there is a microangiopathic changes also there in the pulmonary vasculature. Hyperglycemia per se itself it increases the morbidity and mortality when COVID-19 is associated with diabetes mellitus. These are all the important pathophysiology behind that. And effect of SARS-CoV-2 on blood glucose when the patient is not diabetic, without diabetes, these are all the experience we gained. In SARS-CoV-1, ACE receptors are expressed in pancreatic cells, islet cells, and infection with the SARS-CoV-1 has been seen to cause hyperglycemia. And consistently, even after recovery of SARS-CoV-1, consistently for the next 3 years, hyperglycemia was experienced. So because of consistent destruction of the beta cells. So this is the important studied in SARS-CoV-1 experience. Though the similar effect has not been reported in COVID-19, it may be important to monitor during the COVID-19 period. Patient may get hyperglycemia, so you have to monitor during acute phase as well as during the follow. Next slide. What is the special aspects in management of COVID plus diabetes mellitus? Next slide. The main principle in management of type 2 diabetes mellitus and COVID with diabetes, lifestyle therapy is very important, including medically assisted weight loss, and physical activity and sleep and etc. And avoid hypoglycemia. Whatever the drug you want to choose, please avoid hypoglycemia. Please avoid weight gain and individualize goal and fasting hyperglycemia, postprandial hyperglycemia. You have to control. An optimal A1C target should be kept less than 6.5%. 6.5% or as close as possible without producing hyperglycemia. Therapy of the choice, initiation of the drug depends upon the initial A1C and duration of the diabetes and obesity status. And choice of therapy, initial choice of therapy depends upon the cardiac status, cardiovascular and cerebrovascular status and renal status also very important while selecting the drug. And comorbid condition also very important. You have to address properly to reduce the morbidity and mortality. And you should achieve the goal within 3 months period. And choice of therapy is very important during the COVID period. The cost of therapy also very important. It should be easy to use. And you have to reduce the A1C less than, we have to keep A1C between 6.5 to 7 when the patient is on insulin therapy. But if the patient is on continuous glucose monitoring means you can keep the A1C less than 6.5%. Next slide. So treatment of diabetes and COVID, important thing is problem of getting the nutrition diet is a problem. These are all the challenges we are facing. And opportunities for exercises is limited and regular walking, visit to the gym and swimming pool are not possible. And considerable mental stress due to the unpredictability of the disease as well as social immobility. Stress may lead on to inappropriate eating, overeating or undereating, and oversleep or undersleep. Difficulty in getting medicine also will be there. An economic downfall due to the lockdown. These are all the challenges we are facing while managing the diabetes and COVID-19 patient. What are the role of anti-diabetic drug in current context? The metformin, it has got an anti-proliferatory as well as immunomodulatory effect by inhibition of the cyclic AMP activated protein kinase, which was well proved in mouse model. It reduces it has got a protective role on viral, that is COVID-19 pneumonia. And liraglutide, GLP-1 receptor agonist, actually it increases the ACE2 expression in lungs of rat. It was well proved. So it is harmful in severe COVID-19 patients. And that is clitophons, it increases the risk of pneumonia, viral pneumonia and COVID-19 by upregulation of the ACE2 expression in insulin sensitive cells. And DPP4 inhibitor, these cells, the DPP4 enzyme serves as a receptor for MERS COVID in the same way as ACE2 which was experienced in SARS-CoV-1 and 2. And DPP4 inhibitor actually increases the incidence of upper respiratory tract infection. SGLT2 inhibitor, no data to human pulmonary ACE2. Theoretically, there is a risk of poor outcome. So, drug of choice is insulin and sulfonylurea. Both are safe when you are managing COVID with diabetes. Next slide. So, what are the special aspects of management of, next slide. Previous one, yeah. Metformin, special aspects, next slide, yeah. Metformin gives antiproliferative, next slide. And most patients with mild infection, next slide. Next one, mild infection, previous slide. Most patients with mild infection, normal oral intake means you can continue the same drug, whatever they have previously prescribed. You can continue the same drug when the glycemic control is under good control. And avoid SGLT2 inhibitor whenever there is a severe COVID-19, and metformin can be continued as such, but it can be stopped when the patient is having vomiting and poor oral intake. And doses of other anti-hyperglycemic therapy like sulfonylurea and insulin has to be titrated according to the SMPG reading and fasting postprandial hyperglycemia. And if the patient is critically ill, self-monitoring of glucose is very important, and continuous CGMS also is useful. When you are doing CGM is very much useful when the patient is having COVID-19 positivity, because remotely you can operate and you can give the advice. And some evidence of continuous glucose monitoring, interference with the paracetamol and atenolol and lisinopril. So, but at the same time, it's shown to be useful and reliable in critically ill patients. And as far as hypertension drug, next slide, hypertension drug, any patient parts and taking ACE1 inhibitor or ARB, there are two forms. For current benefits, if the patient is having severe hypertension or uncontrolled hypertension on ACE inhibitor or ARB, or heart failure, for heart failure taking ACE inhibitor or ARB, you have to continue. But that is benefit overweighs the risk of coronavirus infection. So better to continue even the patient is risk of developing COVID-19, and even the patient gets the COVID-19 positivity, still you have to continue when the patient is having severe hypertension and heart failure. And after recovery also you have to continue the same drug. And another form of indication for long-term benefits, the patient is well controlled and mild hypertension. There are two thoughts actually. When the patients are two arms, standard risk of coronavirus infection is present means better to continue. If the patient is getting coronavirus, there is COVID-19, better to stop. After the recovery, you have to resume. And when the patient is having high risk population and healthcare workers and frontline warriors, mild hypertension, better to stop ACE inhibitor and ARB, better to consider to stop ACE and ARB. And if the patient develop COVID-19, stop ACE inhibitor and ARB. After that, he can resume. And concomitant medication, next slide. Statins, definitely you have to continue the statin because it blends the cytokine storms. Calcium channel blocker is very much useful as an antihypertensive therapy in COVID-19 patients. An aspirin, antiplatelet drug, it should be continued unless it's contraindicated in ACE. In ACS also it should be continued. Diabetes management is in poor setting. Nowadays, all the pharmaceutical company, they have reduced the price. Even insulin therapy also has been reduced. Next slide. Next slide. Even all the drugs has been reduced. And you can consider polypill. You can, for reducing the cost, polypill, you can choose the polypill. And a lot of pharmaceutical companies came forward to reduce the price also. Insulin also has been reduced during the corona period. And vitamins can be stopped. Vitamin can be given in a low cost therapy, and polypill like that is atorvastatin, clopidogrel and ACE inhibitor ramipril and metoprolol combination, it can reduce the cost of the therapy in poor settings. You can do that. And special situation, common queries you are getting, even though the blood, next slide, even though the virus, COVID-19 virus, next slide, is present in the blood. Next slide. Next one. Yeah. Even though, can needle prick infect me COVID-19? No. Definitely needle prick or via mosquitoes, it will not spread to the another person. Next slide. Even the COVID-19 positive patient, they can take their pet animal. They will not spread the disease to the pet animal. It's not proved. And when the patient is having acute coronary syndrome, please reconfirm. My dear friend Aravind Kumar, in detail to how to differentiate between acute myocarditis induced by COVID-19 and purely acute coronary syndrome. So you have to differentiate that before taking up for the primary PTCA or secondary PTCA or rescue PTCA, because your life is much more important, precious to treat the future patients. And various form of management you have to do it, whether direct consultation for the COVID-19 with the diabetic patient, only for emergency patient, type 1 uncontrolled patients, and you can do that. Any diabetic emergency, you can do that. Otherwise, virtual communication is very much used. It's very difficult to do that virtual communication. And for the diabetes with multiple comorbid conditions, if the patient is on well controlled, they can continue the same drugs for a couple of months. Next slide. Next slide. Next slide. Yeah. Next slide. Previous slide. Yeah. In ICMR, how to safeguard myself by ICMR guidelines. Reduce your working hours. Tell the patient to sit and you stand. Be careful in measuring BP, especially you can use electronic BP apparatus, and avoid junk depressor, and avoid examining the abdomen. If at all necessary, you do that. Auscultate the lung from the back instead of front, and careful collecting cash from patients, and avoid doctor medical meetings and conferences. You are not the only savior to the patient. To conclude my talk, so metformin in the COVID-19 with the diabetes, mild form of diabetes when the patient is on OP, mild form of diabetes. If the patient is having COVID-19, mild form of or asymptomatic COVID-19, you can continue metformin unless the patient is having vomiting or stomach upset and poor intake. Otherwise, you can continue the metformin because it's a very good effect. It has got a very good effect in COVID-19. But the patient is sick. When the patient is in ICU and the patient is sick, the only two drug of choice are sulfonylurea and insulin. GLP-1 receptor agonist, that is liraglutide, it is also increases the expression of ACE2 expression is very high. So it has to be used very cautiously. Severe patient, it cannot be used. Mild to moderate depends upon the patient situation. You can use HLT2 inhibitor. When the patient is on good control, you can continue the next slide. You can continue the same drug. You can continue the HLT2 inhibitor, mild form or moderate form of COVID-19, that is asymptomatic or mildly symptomatic. HLT2 inhibitor can be continued. But when the patient is in ICU, better to stop because it can produce euglycemic diabetic ketoacidosis. Risk is very high. When the patient is in hospitalization, better to start with the insulin. In ICU, only insulin. And non-ICU patient, insulin plus sulfonylurea as drug of choice. DPP inhibitor also, you have to use it with caution. Severe upper respiratory infection, severe pneumonia, better to stop. You can use insulin and sulfonylureas. And AGI also. And glitazone, it's contraindicated during severe COVID-19 patients. So, thank you very much for the patiently listening. Any queries? I am ready to answer.
Thank you, Dr. Palaniappan, for your wonderful presentation. So now we'll go to the panel discussion part. So we can, I'll request all the speakers and panelists to unmute and their video and audio. Yes, Dr. Arvind.
Yes, please tell me.
Yeah, and Dr. Sampath Kumar is there. Can you please unmute? Okay. The first question we can put to Dr. Palaniappan. It was a very nice presentation. We saw a lot of aspects of especially diabetes management during COVID-19. But I would like to start your first question. Is that in a regular clinic, if you get patients who are early diabetes, because we already know that once type 2 diabetes is diagnosed, almost 50 to 60 to 70% of the beta cell damage has already happened. So do you start with metformin or you go as for the verified trial? Even with HbA1c 6.9, they have suggested to start on a combination of metformin and vildagliptin. So what is your take on this?
So actually, the new onset diabetes mellitus, if the A1C is more than 9%, lifestyle therapy and early insulin therapy plus metformin. Your A1C is 6.9, lifestyle therapy including medically assisted weight loss and good sleep and other that is other good measures, good sleep and regular exercise, all are very important. And directly I have to start with metformin, definitely,
Okay.
because there are two criteria. If the A1C is more than 6.5, definitely metformin has got a role. If the patient is the A1C is 5.8 to 6.4 and fasting hyperglycemia and with HbA1c 5.8 to 6.4, definitely metformin. Only one criteria with pre-diabetes, I will start with only lifestyle therapy. Two criteria, definitely I will add not only lifestyle therapy, I will add metformin. Metformin, after that he can add DPP-4 inhibitor.
Okay, but as for the verified trial, you will not in your practice you will not start with a dual combination. Suppose to save the beta cells, to salvage the beta cells early. So you would not start. You would not prefer starting at 7% HbA1c with a combination of
Yeah,
vildagliptin or
less
gliptin.
than
Yeah.
6.5, single drug is more than enough. Slowly I will uptitrate.
Okay. Now, as you said, in pre-diabetes, as 5.7 to 6.4, would you like to give, because generally you would suggest lifestyle, as you said, lifestyle, weight loss, and everything. But would you suggest to give metformin? Because a combination of metformin and lifestyle might help in reversal of the condition. So what is your suggestion on that?
Yeah, definitely it's got reversal of diabetes is there. That is also transient. Good lifestyle therapy and weight reduction, it can reverse without any pharmacological measures. It can reduce.
Okay.
It can reverse the diabetes.
Okay. Okay, thank you, Dr. Palaniappan. Now, going to Dr. Arvind, with your presentation was in ACS, especially in COVID. Now, what are the main challenges in the management of STEMI during COVID-19 area? What are the key challenges which are there?
Nice question, because this is the order of the day, and it's going to be tough on managing STEMI, because in our setup is a tertiary health center, so we just take the patient for primary PCA whenever the patient comes with a STEMI. And if the patient is not indicated or something like the patient presents late or financial problem, something like that is there, we don't do it. Otherwise, it's most of the time the patient is wheeled into cath lab for a primary PCA. That's the ideal guideline-based therapy which we have been doing. Now with the totally things are changed, and we are practicing more, going back to 2.5 decades back, where fibrinolysis was the order of the day. So now
Okay.
we thrombolize almost all patients, unless if we are forced to do a primary plasty, where
Okay.
we put on the PPE, and the primary plasty is very specific and very clear. When the patient is in cardiogenic shock, requires intervention, that's the point of time where we try to do a primary angioplasty. Otherwise, it's almost always now thrombolysis we do it, and during thrombolysis, just at time of admission, we take a RT-PCR sample and we wheel the patient into, after lysis, into the CT scan room and do a HRCT. So
Yes.
we see the patient basically for silent asymptomatic carriers with COVID pneumonia, and we screen for the presence of RT-PCR antigen. So if it is there, both are there, then we shift the patient into a COVID clinic. We have a COVID ward, which and the medical management of part of the cardiac point of view will be done there in the COVID clinic along with the COVID management. If it is not there, if both of them are negative, we take the patient for an angiogram. Now the plan is not go ahead and do a angioplasty on every patient. Now we visualize the vessel. If it is going to be a triple vessel disease or a left main disease, we just plan for a CABG electively after 2 weeks. Or if the patient has got a amenable lesion for angioplasty, a single vessel or double vessel which is amenable for angioplasty, we go ahead and fix the lesion after 24 hours or 48 hours. That's the point of time where the investigation is.
Okay. Thank you, Dr. Arvind. Now, going to, so we'll come back to you. We have more questions. We'll definitely come back to you. Going to Dr. Sampath Kumar. Can you, I cannot see you. You are on, not, you are muted. Dr. Sampath Kumar. Dr. Sampath Kumar, you are muted. We cannot see you. Okay, we cannot get in touch with him. So going back to Dr. Palaniappan till Dr. Sampath Kumar comes live. So, so the next question is that we are yes, Dr. Palaniappan, you're there? Can you
Yeah.
hear me? Yes.
Yeah.
So the next question is that in diabetes we all know about tight control, conventional control. There are two types of control. So generally we go for the aggressive management, which reduces the microvascular complications. But if you go for a conventional control, a little bit more relaxed, then the chances of macrovascular complications are less. So what do you choose in these patients? Which type of control? If it is a hypertensive patient, if it is a hypertension with type 2 diabetes, what is your choice of therapy? Is it conventional or tight? Is it a CKD? What is your choice? And CAD, patient with CAD, what is your choice in this three?
Yeah, definitely. Usually, the initial period, the newly detected type 2 diabetes mellitus, if you achieve the goal HbA1c less than 6.5, you can reduce the microvascular complication
Yes.
as well as macrovascular complication due to the metabolic memory. Okay,
Yes.
legacy effect.
Yes.
Initial patients. But at the same time, in the ICU, tight control, ICU patients, tight control, you will get a chance of getting hypoglycemia.
Yes.
If it is able to get, the chance of getting hypoglycemia is 8%. 8%. So in that situation, if you can able to titrate properly, slowly you have to titrate the glucose. Then you can reduce the chance of getting hypoglycemia. My choice is definitely many patients. My choice is intensive control in ICU patients. Non-ICU patient, conventional therapy. Conventional therapy, slowly you have to titrate. When the patient is having CKD patient, the chances of getting hypoglycemia is very high.
Yes.
So slowly you have to conventional therapy is much more better in case of CKD, especially stage 4 and 5. Stage 3 AB is okay, but stage 4 and 5 chance of getting hypoglycemia is very high. So you can keep the target less than 7%. Other patients and all you can reduce to less than 6.5%. Coronary heart disease patients definitely you have to keep between 6.5 to 7%, because hypoglycemia itself can kill the patient because of arrhythmia, sudden cardiac death. A lot of things are reported. So coronary heart disease patient, intensive therapy I won't do. So conventional therapy, slowly you have to titrate. That is a choice. And usually diabetes, if you control diabetes, you can reduce the microvascular complication. If you do the control, very good control in the early phase itself, you can prevent macrovascular complication. But macrovascular complication causes multifactorial, not only diabetes, insulin resistance, dyslipidemia, as well as insulin resistance, dyslipidemia and obesity. So you have to address all the things. It's a multifactorial to prevent macrovascular complication.
Okay. Thank you. That was very good. I mean, there was pinpointed information which we got, very useful in the management. Now, going to Dr. Arvind, your ACS patients generally will need, ACS patients might need, or the AF patients, atrial fibrillation patients also, they will need anticoagulation. So, in these patients, what do you do? Because warfarin, because now they cannot go regularly for doing routine INR monitoring.
Rajesh?
So what, yeah. So what do you do in these patients? Do you prefer more of NOACs in this patient? So what is your, and if the patient is already on acinocomerol or warfarin, do you switch them? What do you do, Dr. Arvind?
Good question. See, there is clearly there are definite guidelines for giving a warfarin or acetocomerol and NOAC. So when case of valvular AF, that means patient has got a mitral stenosis where left atrial pressure is very high. It means that valvular AF or prosthetic valve related atrial fibrillation. There is no question or choice of giving NOAC. It's only warfarin and acetocomerol. So whatever may be there, we have to continue. So we have to find a solution for measuring their PTINR. So what I do is I just try to guide the patient to the nearest center. I do teleconsultation also.
Okay.
So I just choose the lab which is reliable to me in the particular area of And from there, I ask them to report to the lab, and from there, I get the lab result, and through teleconsultation, I manage the INR and prevent the patient from traveling to my all the way to meet me, so that the chance of getting infected on the way is much lesser, so patient is much more safer. So this is how I manage the patient. The guidelines are very simple and straightforward. Prosthetic valve and valvular AF, there is no option of NOAC. But the patient is already on warfarin or asthma, the patient has got a non-valvular atrial fibrillation, or say a DVT or a pulmonary embolism on follow-up, with regard to the protein C or protein S deficiency, like something like that. Then I prefer the patient now to switch over to NOAC. So whatever may be the condition like. So there are definitely every NOAC has got an advantage. Dabigatran has got its own advantage, and the apisiban has got one. So rivaroxaban has its own. So to make it very clear and precise, in case of atrial fibrillation, you get the coronary artery disease and you have stented, rivaroxaban is a drug of choice. In
Okay.
case of
Okay.
atrial fibrillation, with a stroke, dabigatran has got a drug of choice. In case of atrial fibrillation, with a GA bleed, rivaroxaban cannot be given. A dabigatran and apisiban. In case of renal failure, apisiban. In elderly, apisiban. So like this, the NOAC, the guidelines is very crystal clear. So dabigatran has got a role in atrial fibrillation with a stroke or pre-past history of stroke. Atrial fibrillation with coronary artery disease post-stenting, rivaroxaban. Atrial fibrillation, elderly population, renal failure, GA bleed, apisiban. That's all. Simple. Make it simple. And in case of pulmonary embolism, similarly, you can take any NOAC. I am comfortable with all NOACs, and no guidelines is giving a precedent over the other one. And in case of DVT also. And the duration of DVT and pulmonary embolism depending on the triggering factor and the spontaneous activity, and more importantly, the predisposing factor like a protein C, protein deficiency, or an anti-thrombin 3 deficiency, I will before starting it, I will measure it, and accordingly I will decide on the duration of my oral anticoagulation.
Okay, thank you, Dr. Arvind. Now going to Dr. Sampath Kumar, who was Dr. Kumar, you have joined. So the first question for you is that how do you manage the hyperkalemia in ARF, and what are the factors and drugs which can exacerbate the situation? Is number 2, and how do you interpret the ECG, and what are the things we should look in the ECG as a warning telltale sign?
Yeah, hyperkalemia is an ever-present danger, and it can be even before he reaches the dialysis room. So
Yes.
the first thing is suspicion. So whenever a patient with acute renal failure develops a bradycardia, if the pulse rate is lower than 70, then immediately you should ask for an ECG. And one of the first things that in the ECG that you will see is in the chest wall leads, that you will find the T waves become tall and taller than the chorus. So that is the first sign that you are dealing with hyperkalemia. There could be a disconnect between the potassium levels that you get in the labs and the ECG. If either one of them is abnormal, you have to act. You may sometimes have an absolutely normal appearing ECG and very severe hyperkalemia. On the other hand, you may have ECG changes with the potassium levels hovering around 4.7 or 4.8. Just to tell you that it is the local concentration and how the potassium levels affect the myocardium is more important. So you will have to start acting when the serum potassium levels go beyond 5.5, when it is added on to metabolic acidosis. So because acidosis, as I already told you in a slide, that acidosis pushes the potassium from the cell into the plasma. So you need to correct the acidosis and give calcium gluconate intravenously. And in a diabetic patient, you can't start dextrose insulin infusion because already they will be hypoglycemic. So the other method will be to give soda bicarbonate infusion. So you will have to be aware that one of the, hyperkalemia is one reason why you start preparing the patient for dialysis. So you can't wait and do all these pharmacological therapy in a patient with hyperkalemia and acute kidney failure. So this is an indication that you will have to dialyze the patient and quickly push up the potassium from the body.
Okay. Okay, that's good. Sir, we'd like to ask you another question, I mean, which is there. Sir, your presentation was on acute kidney injury. Now, that's a severe condition, but in the COVID-19 patient, what are the added challenges which are faced by you? And how do you manage the situation? Which form of dialysis is more suitable in these patients? So what is your take on this?
So the problem is, we have every day we are confronted by patients who come to our hemodialysis units, maintenance hemodialysis patients on chronic renal failure, renal disease. So the surgeons will have protocols in place saying that they will operate only when they have COVID negative patients. So no such possibilities are available for the poor nephrology, because day in and day out, on a weekly thrice basis, these patients are coming to the community into the dialysis room and goes back to the community. So we cannot be testing a patient on every session, every day for COVID. So we have to leave things to God and have personal protection, safety of the technicians, the equipments in place, and then go ahead thinking that the whole dialysis unit is having COVID positive patients. That is the only way to go.
Okay, good. Sir, DIC is found to be a leading cause of mortality in COVID-19 patients. We have seen so many patients dying on that. So do you prefer, once they're in the hospital, any type of prophylaxis to give so that they do not fall prey to DIC?
I don't think we have seen a situation of DIC. It is actually clotting, which can predispose towards the clotting of the dialyzers that we see in, which we use in chronic kidney disease patients. Dialyzers and also the lines clotted if the patient has got a cytokine storm. Though they have to be given a higher dose of heparin, have to be taken up for dialysis.
Okay. Thank you, sir. We'll come back to you again with the questions. So, going to Dr. Palaniappan. So, your question is, so this is a common question to all three of you. So, we'll start with Dr. Palaniappan. What is your view of SGLT2 in general in type 2 diabetes with specific reference to COVID-19 era?
Indication of SGLT2 inhibitor in type 2 diabetes mellitus.
Yes. With specific relation to COVID-19 era. The patient might be COVID negative also, but if it is like coming to you, what do you do? How do you manage the patient? Or if it is a COVID positive patient without any symptoms, so what do you do?
SGLT2 inhibitors are such a wonderful drug. I am using plenty of SGLT2 inhibitors in my clinical practice. If the patient is having COVID-19 that is negative, definitely I will continue. If it is positive and asymptomatic, now WHO says asymptomatic COVID patients are not infectious. Now, so asymptomatic patient SGLT2 inhibitor can be continued. If the patient is on already SGLT2 inhibitor, there is no problem, good glycemic control, let him continue. And as well as I will give advice, take plenty of water unless it's contraindicated in heart failure or renal failure. You have to take plenty of water, and hydration is very, very important for continuing SGLT2 inhibitor. Mild, that is asymptomatic patient, definitely I will continue SGLT2 inhibitor. When the patient is a hospitalized patient, non-ICU and ICU. Non-ICU patient, when the patient's hydration is good, still I will continue SGLT2 inhibitor. But if the patient is sick, acutely ill, patient is having high grade fever, definitely I will stop. Any acute illness, SGLT2 inhibitor, it has to be stopped immediately, because severe dehydration, which will precipitate hypotension and acute kidney injury, what my dear friend Dr. Sampath Kumar sir also told. So acutely ill, definitely I will stop SGLT2 inhibitor. After the recovery of COVID-19, I will restart SGLT2 inhibitor slowly. An acutely ill patient, definitely there is no role because it may precipitate euglycemic diabetic ketosis also. So asymptomatic patient, I will continue SGLT2 inhibitor and I will watch for all those things, hydration, everything, BP, everything I will watch out.
Okay. Thank you, Dr. Palaniappan. Now we'll go to Dr. Arvind. The theme is the same, SGLT2 inhibitors. Now, if you get a patient because diabetic patients are more prone to develop ACS in the future. Now, if you get such a patient in with SGLT2 inhibitor, what will you do? Will you continue this drug in your ACS patient, or you want to stop it? So, what is your way in this COVID-19 era?
It's a good question, but I am not the right person to answer, I believe, because I practice only pure cardiology, and we have a very, very strong team for diabetic management, and I hand over the diabetic part to them. But theoretically speaking, as Dr. Palaniappan put it across, there is a wonderful drug. There is no doubt about it, because I can only talk here because I am not practicing. But in the case of diabetes with coronary disease with the LV dysfunction, volume overload status is there. If there is no contraindication, if there is lower urinary tract infection or an obstructive uropathy or BPH or something like that, where my little care is so, except these patients where I require a decongestion, definitely I will continue with this. There is no doubt. I will allow my diabetologist to continue with this. And during an acute MI situation, most of the time we prefer to convert it into a insulin rather than going for any medication. And periodically titrating the sugars along with the insulin is best way of modality, where we have found healing of myocardium is much better with insulin rather than with continuing the medication.
Okay, going to going to Dr. Sampath Kumar. So, sir, your presentation was on AKI, but if you permit me, I'll just little bit deviate from AKI to chronic kidney disease, if you permit me. So the question is that because if in the ICU, you might be getting a lot of patients with electrolyte disturbance, or say without electrolytes, a lot of CKD patients. Now, in this particular, if they are on SGLT2 and come to the ICU, how do you manage the patient? What do you do with the SGLT2? Because a lot of patients, because a lot of companies are there which are having SGLT2 now. It's a common drug now, like metformin. So what do you do in these patients?
No, SGLT2 inhibitors are not used in chronic kidney disease because they have to act through a good glomerular filtration. So if their GFR is low, they have no role to play in control of blood sugars. So that is number one. Number two, we do get cases of dyselectrolytemia and also ketosis, non-hyperglycemic ketosis in emergencies. We have seen patients with a serum bicarbonate level of as low as 2 or 3 single-digit numbers in patients who are put on SGLT2. So it is ideal that the physicians are aware that in COVID-19 situation, where the patients cannot reach the hospital as easily as before, it is ideal that an awareness has to be spread among the physician that SGLT2 inhibitors are very good, powerful drugs, but they have to be very carefully monitored. At the slightest hint of medical illness, the patients have to be well advised to stop the drug and go for insulin therapy. And that was very nicely articulated by Dr. Palaniappan. He has said that at the slightest hint of medical illness, these drugs have to be stopped.
Okay, thank you, Dr. Kumar. Now we have answered most of the questions, and we have already 1 hour 50 minutes into the program, so I think it's time. And now we are coming to a close. Regarding the number of logins, 911 people have logged in and watching this program. So that's nearly 1,000 logins. So I would like to take key messages from all the speakers now. So Dr. Kumar, you can give your key message to the audience from your side today.
Yeah, the key message is that in patients with renal failure or renal disease, these patients have to be very carefully monitored when they come into ICU, and especially when they have acute kidney injury. The electrolyte profile has to be looked into, and you need to monitor the electrolyte profile and also provide them with the proper intravenous fluid as a highlighted with a lower chloride solution, so that the acute kidney injury incidence is brought down, and this is an important message. Second is the drug therapy. In diabetics, the drug therapy have to be carefully handled, and insulin will be an ideal method of treatment. SGLT2 inhibitors have their downsides in the ICU. You have to, a note of caution is necessary here. Thank you.
Dr. Arvind, your key message to the audience?
The key message is, because I'm talking about ACS, the key message for me is very simple. Now we have gone back to lysis most of the patients. So the key message to all my friends who have been referring, and to the people who are listening, referring to the center of PCA capable center. Anyhow, most of the centers are going to only thrombolyze. So don't waste time in shifting the patient to a PCA capable center for thrombolysis, which is going to add another 1 hour or 2 hours of total ischemic time. So please thrombolyze in the place wherever it is there, and shift the patient for the intervention where pharmaco-invasive treatment is going to be the order of the day. So please thrombolyze the patient without wasting time. That is one of the key message which I want to pass. And for non-aspiration unstable angina, we are not going to anyhow shift the patient to the cath lab straight away from the casualty. So you are going to stratify the patient accordingly planned. So you can either manage the low risk patient in your center, and the high risk patient where recurrent breast angina or hemodynamic instability, the patient may be shifted to the center of interest of PCA capable center and proceed with it. Otherwise, most of the patients can get better with the medical management at this point of time.
Thank you, Dr. Arvind Kumar. Now going to Dr. Palaniappan, your key message to the audience.
Yeah, COVID with the diabetes. The key message is, when the patient is asymptomatic, if the patient is already in good control with the previous medication, anti-diabetic drug, whether oral or insulin, please continue the same in asymptomatic COVID patient with the diabetes for controlling. If the patient is a hospitalized patient, non-ICU, ICU, the insulin is a drug of choice. And non-ICU patient, if the patient, we can continue insulin plus oral anti-diabetic drug to get a good glycemic to achieve a better glycemic target. And especially metformin can be continued. It's a good effect, and usually that is SGLT2 inhibitor also can be continued in asymptomatic patient, but it's contraindicated in moderate to severe COVID positive patients. ICU sick patient, the only drug of choice is insulin. Non-ICU patient, sulfonylurea and insulin is the drug of choice. Others, depends upon the situation and patient, other comorbid condition, you can choose, add or delete. And after complete recovery, you can resume the previous drugs, whatever you are on, with good glycemic control.
Thank you very much. Yes.
Thank you.
So, yes. So we have come to the end of this program. So I would like to thank Dr. Palaniappan, Dr. Arvind, Dr. Sampath Kumar for going in this for being in this program. Such a nice presentation, such a nice discussion. We got answers to a lot of queries for the audience. I would like to thank the technical team. I would like to thank Ipca for organizing this program. We have around 1,000 logins, 911 or more. So thank you very much. We hope to see in the future very soon with more such programs. So till then, goodbye. Thank you. Best of luck. Keep safe. Thank you. Thank you.
Thank you very much, Indranil, Arvind and Sampath Kumar sir. Thank you very much for the wonderful opportunity, sir. Thank you, sir. Bye, sir.
Thank you.
Arvind, bye.
Bye.
எப்பா, எடுங்கப்பா முதல்ல, அங்கவே முடியல.